Welcome to The Sleepy Pharmacist. This channel shares calm, factual information about medicines and pharmacology. In this video, you'll hear quiet facts about sedative-hypnotics, antihistamines, and melatonin, designed to help you learn gently and fall asleep. You can listen actively or let the information fade into the background as you rest. The word barbiturate may derive from Saint Barbara, the patron saint of artillerymen. Adolf von Baeyer synthesized barbituric acid on December 4, 1864. That date is the feast day of Saint Barbara. On the day of the discovery, Baeyer reportedly visited a tavern where artillery officers were celebrating their patron saint. This festive setting is often cited as inspiration for the compound's name. Another theory suggests that Baeyer named the compound after a woman he knew named Barbara. The exact origin of the name barbiturate remains unknown. A third theory proposes that the name comes from the German word for the notched part of a key. This word sounds similar to the first syllable of barbiturate. Barbituric acid itself has no effect on the central nervous system. It serves as a chemical building block for other drugs. The first commercially successful barbiturate was called Veronal. It was brought to market in 1903. Veronal was named after the Italian city of Verona, which one of the inventors considered to be the most peaceful city he knew. Joseph von Mering was reportedly visiting Verona when he learned that his new compound worked. He named it on the spot. Veronal became widely popular in the early 20th century. It was sold as cocoa-flavored tablets designed to make the bitter compound easier to consume. More than 2,500 barbiturate compounds were synthesized during the 20th century. Only about 50 of those compounds were ever used in clinical settings. Phenobarbital was first marketed in 1912 under the brand name Luminol. The name luminol evokes the idea of light. Phenobarbital is the oldest seizure medication still in common use. It has been available for more than 100 years. Phenobarbital is included on the World Health Organization list of essential medicines. It remains widely used in many parts of the world. During World War II, military personnel in the Pacific region were given barbiturates informally called goofballs. These were intended to help soldiers cope with heat and humidity. Chloral hydrate was the first synthetic sedative hypnotic compound. It was first produced in 1832. Chloral hydrate was synthesized by Justus von Liebig. He was the same chemist who identified the role of nitrogen in fertilizers. Chloral hydrate was introduced for medical use in 1869. It remained in use for over a century. The phrase Mickey Finn refers to a drink laced with an incapacitating substance. The term originated in the early 20th century. The phrase comes from Michael Finn, a Chicago bartender who operated the Lone Star Saloon from 1896 to 1903. He was reportedly accused of adding knockout drops to customers' drinks. The incapacitating substance commonly associated with that era was chloral hydrate. It dissolves easily in alcohol and has a mild taste. Potassium bromide was the first widely used sedative compound. Its sedating properties were described in 1857. Bromide salts were available in over-the-counter products for many decades. They were removed from the United States market in 1975 due to concerns about chronic toxicity. The word bromide is sometimes used in English to mean a dull or commonplace remark. This slang usage comes from the sedating effects of bromide salts. The drug Phenobarbital was given the trade name Nembutal. The name was coined by John S. Lundy at the Mayo Clinic in 1930. Nembutal is a portmanteau derived from the drug's chemical structure. It combines the letters for sodium, ethyl, methyl, and butyl. Among the first people to receive Nembutal were Lundy's wife, the co-founder of the Mayo Clinic, and the boxer Jack Dempsey. This was documented in early clinical reports. Diphenhydramine was discovered in 1943 by George Reveshel at the University of Cincinnati. He was searching for muscle relaxants when he identified a compound that blocked histamine. George Reveshel originally hoped to become a commercial artist. He could not find work during the Great Depression and turned to chemistry instead. Reveshel's compound became known as Benadryl. It became the first antihistamine approved by the United States Food and Drug Administration in 1946. The discovery of diphenhydramine eventually contributed to the development of fluoxetine. Fluoxetine is also known by the brand name Prozac. First-generation antihistamines cross into the brain and block histamine receptors there. This activity is associated with the sedating effect of older antihistamines. Histamine is a neurotransmitter that promotes wakefulness. Blocking histamine activity in the brain can produce drowsiness. Neurons that release histamine in the brain are found in a small region called the tuberomammillary nucleus. This region is located in the posterior hypothalamus. The tuberomammillary nucleus is the only region of the mammalian brain that produces neuronal histamine. It is a very small cluster of cells. There are approximately 64,000 histamine-producing neurons in the human brain. These neurons send projections throughout the central nervous system. Histamine neurons fire during wakefulness and become silent during sleep. Their activity is closely correlated with vigilance. Doxylamine is another first-generation antihistamine with sedating properties. It is found in some over-the-counter sleep aids. Hydroxyzine was approved by the United States Food and Drug Administration in 1959. Unlike diphenhydramine and doxylamine, it remains available by prescription only. Tolerance to the sedating effects of antihistamines can develop within days. This pattern has been observed in various studies. Benzodiazepines enhance the activity of gamma-aminobutyric acid at its receptors. Gamma-aminobutyric acid is the brain's primary inhibitory neurotransmitter. Flurazepam was the first benzodiazepine marketed for nighttime use. It was approved in 1970. Triazolam and temazepam are also benzodiazepines. They belong to the same pharmacological class as flurazepam. In September 2020, the United States Food and Drug Administration required updated warnings for all benzodiazepines. The warnings described the risks of dependence and withdrawal. The sleeping pill triazolam, sold under the brand name Halcyon, was banned in the United Kingdom in October 1991 after concerns were raised about psychiatric side effects. A woman in Utah cited Halcyon intoxication as a legal defense in a murder case in 1988. The criminal charges against her were dismissed. Halcyon remains available in the United States and many other countries. Regulatory approaches to this drug have varied by jurisdiction. Zolpidem was synthesized in the early 1980s by researchers at a French pharmaceutical company called Synthelabo. It belongs to a class sometimes called Z-drugs. Z-drugs bind selectively to a specific subunit of the gamma-aminobutyric acid A receptor. This selectivity distinguishes them from benzodiazepines. Zolpidem was first marketed in France in 1988. It reached the United States market in 1992 under the brand name Ambien. Esopiclone was approved by the United States Food and Drug Administration in December 2004. It was the first hypnotic approved without restrictions on duration of use. The Orexin system and the hypocretin system refer to the same neurochemical system. They were discovered by two independent research teams in 1998. One research team named the neuropeptide Orexin from the Greek word for appetite. The other team named it hypocretin because it was found in the hypothalamus and resembled incretin hormones. Both discoveries were published in the same year without either team knowing about the other team's work. This coincidence is well documented in scientific literature. Orexin neurons are located in the lateral hypothalamus. There are approximately 50,000 to 80,000 of these neurons in the human brain. Orexin promotes and stabilizes wakefulness. The absence of orexin is associated with narcolepsy. Suvorexant was the first orexin receptor antagonist to reach the market. It was approved by the United States Food and Drug Administration in August 2014. Daridorexant received marketing authorization in the European Union in April 2022. It became the first orexin antagonist available in Europe. Orexin receptor antagonists work by blocking wake-promoting signals in the brain. This mechanism differs from drugs that broadly depress central nervous system activity. Melatonin is produced by the pineal gland, a small structure deep in the brain. The pineal gland releases melatonin in response to darkness. Melatonin signals to the body that nighttime has arrived. It is sometimes called the hormone of darkness. Melatonin is not a sedative in the traditional sense. It is described as a chronobiotic, meaning it signals circadian timing rather than directly inducing sedation. Ramelteon was approved by the United States Food and Drug Administration in July 2005. It binds to the same receptors in the brain that melatonin binds to. These receptors are called melatonin receptor 1 and melatonin receptor 2. They are located in a brain region called the suprachiasmatic nucleus. The suprachiasmatic nucleus is a tiny region in the hypothalamus. It keeps track of time and coordinates circadian rhythms throughout the body. Tasimelteon was the first drug approved for non-24-hour sleep-wake disorder. This condition primarily affects people who are completely blind. Ramelteon was not approved in the European Union. The marketing authorization application was withdrawn in 2008. Neither Ramelteon nor Tasimelteon is classified as a controlled substance. They are not considered to have significant abuse potential. Sleep is divided into two broad categories called rapid eye movement sleep and non-rapid eye movement sleep. Non-rapid eye movement sleep comprises approximately 75 to 80% of adult sleep time. Rapid eye movement sleep is associated with dreaming. It makes up approximately 20 to 25% of total adult sleep time. Acetylcholine activity is highest during waking and during rapid eye movement sleep. During deep, non-rapid eye movement sleep, acetylcholine activity is at its lowest. Gamma-aminobutyric acid is the brain's primary inhibitory neurotransmitter. Neurons that release gamma-aminobutyric acid in the basal forebrain are associated with promoting sleep. Barbiturates dominated sedative use from approximately 1903 until the 1960s. They were gradually replaced by benzodiazepines. Barbiturates work by increasing the duration that chloride ion channels stay open at gamma-aminobutyric acid receptors. This is different from how benzodiazepines work. Austrian writer Stefan Zweig died in 1942 from an overdose of Veronal while he was living in Brazil. The Japanese writer Ryunosuke Akutagawa deliberately overdosed on Veronal in 1927. Veronal was commonly available during that era. The brand name Luminal for Phenobarbital was introduced by Bayer in 1912. The name suggests illumination or light. Alfred Hauptmann was a young German doctor who first observed that phenobarbital reduced seizures after he gave the drug to his patients as a tranquilizer and noticed their seizures improved. Hauptmann's observation was made in 1912, the same year Luminal was marketed. This was considered an accidental discovery. Before phenobarbital, bromide salts were the main treatment available for seizures. Bromides had significant side effects and limited effectiveness. The tuberomammillary nucleus sends projections throughout the brain. These projections reach areas involved in attention, memory, and arousal. Histamine neurons in the tuberomammillary nucleus display a slow, irregular firing pattern during wakefulness. their firing rate is highest during attentive waking states. When histamine neurons stop firing, the brain begins to transition towards sleep. This cessation of activity occurs before the onset of sleep-related brainwave patterns. The ventrolateral preoptic area is a brain region associated with sleep promotion. It sends inhibitory signals to wake-promoting regions, including the tuberomammillary nucleus. The relationship between sleep-promoting and wake-promoting brain regions has been described as mutually inhibitory. When one is active, the other tends to be suppressed. Diphenhydramine was originally tested as a potential muscle relaxant. Its antihistamine properties were discovered unexpectedly. Fred Huber, a student of George Reveshel, was the first to synthesize the compound that became diphenhydramine. Reveshel then worked with a pharmaceutical company to develop it further. Diphenhydramine became available over the counter in the United States in 1982. Before that, it was available only by prescription. First-generation antihistamines have anticholinergic properties in addition to their histamine blocking effects. This contributes to some of their side effects. The Beers criteria is a list of medications that may be inappropriate for older adults. First-generation antihistamines are included on this list. Second-generation antihistamines were designed to have less effect on the central nervous system. They are less likely to cause drowsiness than first-generation antihistamines. The difference between first and second-generation antihistamines relates to how easily they cross into the brain. Second-generation antihistamines have more difficulty crossing the blood-brain barrier. Hydroxyzine belongs to a chemical class called piperazines. It was approved decades before many other sedating antihistamines became available over the counter. The compound chloral was first produced in 1832. When water is added to chloral, it becomes chloral hydrate. Chloral hydrate was widely used in the 19th century for sedation and for inducing sleep. It was considered safer than some alternatives available at the time. The use of chloral hydrate declined over the 20th century as newer sedatives became available. It is now rarely used in most countries. Benzodiazepines were first introduced in the 1960s. They were considered a significant advance over barbiturates in terms of safety. Chlordiazepoxide was the first benzodiazepine to be marketed. It was introduced in 1960 under the brand name Librium. Diazepam followed shortly after and became widely known under the brand name Valium. It was introduced in 1963. The word benzodiazepine refers to the chemical structure of these compounds. They contain a benzene ring fused to a diazepine ring. Benzodiazepines increase the frequency of chloride channel opening at gamma-aminobutyric acid receptors. Barbiturates increase the duration of channel opening. This difference in mechanism helps explain why benzodiazepines are generally considered to have a wider margin of safety than barbiturates. This distinction was recognized in early pharmacological research. Triazolam has a relatively short half-life compared to many other benzodiazepines. This means it is eliminated from the body more quickly. Temazepam has an intermediate half-life among benzodiazepines. It was developed for use as a nighttime sedative-hypnotic medication. Flurazepam has a long half-life and produces active metabolites that persist in the body. This can lead to next-day impairment in some individuals. The half-life of a drug refers to the time it takes for half of the drug to be eliminated from the body. Drugs with longer half-lives remain active for longer periods. Z drugs were developed in the 1980s as alternatives to benzodiazepines. The letter Z refers to the names of the early compounds in this class. Zolpidem, Zaleplon, and Zopiclone are the three original Z drugs. Esopiclone is a later addition to this class. Zaleplon has a very short half-life, even shorter than Zolpidem. It is eliminated from the body within a few hours. Zopiclone is available in many countries but is not approved in the United States. Esopiclone, a related compound, is the form available in the United States. The alpha-1 subunit of the gamma-aminobutyric acid A receptor is associated with sedation. Z drugs bind preferentially to this alpha-1 subunit. Benzodiazepines bind to multiple subunits of the gamma-aminobutyric acid A receptor. This broader binding profile contributes to their wider range of effects. The gamma-aminobutyric acid A receptor is a protein complex that forms a channel for chloride ions. When activated, it allows chloride to flow into the neuron. Fred Huber, a student of George Reveschel, was the first to synthesize the compound that became diphenhydramine. Reveschel then worked with a pharmaceutical company to develop it further. Diphenhydramine became available over the counter in the United States in 1982. Before that, it was available only by prescription. First-generation antihistamines have anticholinergic properties in addition to their histamine blocking effects. This contributes to some of their side effects. The Beers criteria is a list of medications that may be inappropriate for older adults. First-generation antihistamines are included on this list. Second-generation antihistamines were designed to have less effect on the central nervous system. They are less likely to cause drowsiness than first-generation antihistamines. The difference between first and second-generation antihistamines relates to how easily they cross into the brain. Second-generation antihistamines have more difficulty crossing the blood-brain barrier. Hydroxyzine belongs to a chemical class called piperazines. It was approved decades before many other sedating antihistamines became available over the counter. The compound chloral was first produced in 1832. When water is added to chloral, it becomes chloral hydrate. Chloral hydrate was widely used in the 19th century for sedation and for inducing sleep. It was considered safer than some alternatives available at the time. The use of chloral hydrate declined over the 20th century as newer sedatives became available. It is now rarely used in most countries. Benzodiazepines were first introduced in the 1960s. They were considered a significant advance over barbiturates in terms of safety. Chlordiazepoxide was the first benzodiazepine to be marketed. It was introduced in 1960 under the brand name Librium. Diazepam followed shortly after and became widely known under the brand name Valium. It was introduced in 1963. The word benzodiazepine refers to the chemical structure of these compounds. They contain a benzene ring fused to a diazepine ring. Benzodiazepines increase the frequency of chloride channel opening at gamma-aminobutyric acid receptors. Barbiturates increase the duration of channel opening. This difference in mechanism helps explain why benzodiazepines are generally considered to have a wider margin of safety than barbiturates. This distinction was recognized in early pharmacological research. Triazolam has a relatively short half-life compared to many other benzodiazepines. This means it is eliminated from the body more quickly. Temazepam has an intermediate half-life among benzodiazepines. It was developed for use as a nighttime sedative-hypnotic medication. Flurazepam has a long half-life and produces active metabolites that persist in the body. This can lead to next-day impairment in some individuals. The half-life of a drug refers to the time it takes for half of the drug to be eliminated from the body. Drugs with longer half-lives remain active for longer periods. Z drugs were developed in the 1980s as alternatives to benzodiazepines. The letter Z refers to the names of the early compounds in this class. Zolpidem, Zaleplon, and Zopiclone are the three original Z drugs. Esopiclone is a later addition to this class. Zaleplon has a very short half-life, even shorter than Zolpidem. It is eliminated from the body within a few hours. Zopiclone is available in many countries but is not approved in the United States. Esopiclone, a related compound, is the form available in the United States. The alpha-1 subunit of the gamma-aminobutyric acid A receptor is associated with sedation. Z drugs bind preferentially to this alpha-1 subunit. Benzodiazepines bind to multiple subunits of the gamma-aminobutyric acid A receptor. This broader binding profile contributes to their wider range of effects. The gamma-aminobutyric acid A receptor is a protein complex that forms a channel for chloride ions. When activated, it allows chloride to flow into the neuron. The influx of chloride ions makes neurons less likely to fire. This is the basis of the inhibitory effect of gamma-aminobutyric acid. Orexin was originally studied in relation to appetite regulation. The name orexin comes from the Greek word for appetite. Researchers initially observed that orexin increased feeding behavior in laboratory animals. The connection to wakefulness was discovered later. The hypocretin name was chosen because the compound was found in the hypothalamus and had structural similarities to incretin hormones. Incretins are hormones involved in metabolism. In 1999, researchers discovered that dogs with narcolepsy had a mutation in the orexin receptor gene. This was a major breakthrough in understanding the disorder. Also in 1999, mice lacking orexin were observed to have symptoms resembling narcolepsy. These findings established the link between orexin and sleep regulation. In 2000, researchers found that most humans with narcolepsy had lost the neurons that produce orexin. This loss appeared to be the result of a degenerative process. The exact cause of orexin neuron loss in narcolepsy is still being studied. Current evidence suggests an immune-related mechanism may be involved. Suvorexant blocks both orexin receptor subtypes. These subtypes are called orexin receptor 1 and orexin receptor 2. Lemborexant is another dual orexin receptor antagonist. It was approved by the Food and Drug Administration in December 2019. Health Canada authorized Lemborexant in 2020. It became available in Canada under the brand name Dayvigo. Daridorexant was approved by Health Canada in 2023. It is marketed under the brand name Quviviq. The European Medicines Agency authorized daridorexant in April 2022. This made it the first orexin antagonist available in Europe. Orexin receptor antagonists represent a different approach to promoting sleep compared to older drug classes. They reduce wakefulness signals rather than broadly suppressing brain activity. The suprachiasmatic nucleus contains approximately 20,000 neurons in humans. It receives direct input from the eyes through a pathway called the retinohypothalamic tract. Light exposure during the day helps synchronize the suprachiasmatic nucleus to the external environment. This is how the body maintains a roughly 24-hour rhythm. People who are completely blind may have difficulty synchronizing their internal clock to the external day-night cycle. This can result in non-24-hour sleep-wake disorder. Tasimelteon was approved for non-24-hour sleep-wake disorder in January 2014. It was the first medication approved specifically for this condition. The pineal gland is located near the center of the brain between the two hemispheres. It is a very small structure, roughly the size of a grain of rice. The pineal gland was historically called the seat of the soul by the philosopher René Descartes. This was based on speculation rather than scientific evidence. Melatonin production increases in the evening as light levels decrease. Production typically peaks in the middle of the night. Exposure to bright light at night can suppress melatonin production. This is one reason why light exposure affects sleep timing. The melatonin receptor 1 is associated with promoting sleepiness. The melatonin receptor 2 is associated with shifting circadian timing. Ramelteon has affinity for both melatonin receptor 1 and melatonin receptor 2. Its effects are thought to involve both sleepiness promotion and circadian adjustment. Circadian rhythms affect many body functions beyond sleep and wakefulness. Body temperature, hormone release, and metabolism all follow circadian patterns. The word circadian comes from the Latin words circa and dies, meaning about a day. Circadian rhythms have a period of approximately 24 hours. Without external time cues, the human circadian rhythm tends to drift slightly longer than 24 hours. This is called the free running period. Time cues that help synchronize circadian rhythms are called Zeitgebers. This is a German word meaning time givers. Light is the most powerful Zeitgeber for humans. Non-rapid eye movement sleep is divided into 3 stages. These stages represent progressively deeper levels of sleep. Stage 1 of non-rapid eye movement sleep is the lightest stage. It typically occurs during the transition from wakefulness to sleep. Stage 2 of non-rapid eye movement sleep is characterized by specific brainwave patterns, including sleep spindles and K-complexes. Stage 3 of non-rapid eye movement sleep is the deepest stage. It is sometimes called slow-wave sleep because of the slow brainwave patterns that occur during this stage. Slow-wave sleep is most abundant in the first third of the night. The proportion of rapid eye movement sleep increases as the night progresses. Sleep cycles typically last about 90 minutes. A full night of sleep usually includes 4 to 6 complete cycles. The proportion of time spent in different sleep stages changes across the lifespan. Slow-wave sleep decreases with age. Rapid eye movement sleep is sometimes called paradoxical sleep. This name refers to the fact that brain activity during this stage resembles wakefulness even though the person is asleep. During rapid eye movement sleep, most voluntary muscles are temporarily paralyzed. This is called atonia and is thought to prevent people from acting out their dreams. The brainstem contains regions that are important for generating rapid eye movement sleep. These include the pons and adjacent structures. The locus coeruleus is a small brainstem structure in the pons that releases norepinephrine, a neurotransmitter associated with alertness and arousal. Neurons in the locus coeruleus are most active during wakefulness. Their activity decreases during non-rapid eye movement sleep and becomes nearly silent during rapid eye movement sleep. The dorsal raphe nucleus is another brainstem structure involved in sleep-wake regulation. It releases serotonin, which has complex effects on arousal. Similar to the locus coeruleus, the dorsal raphe nucleus is most active during wakefulness. Its activity decreases during sleep. The basal forebrain contains neurons that release acetylcholine. These cholinergic neurons project to the cerebral cortex and influence cortical activity. Acetylcholine release in the cerebral cortex is associated with both wakefulness and rapid eye movement sleep. This helps explain why brain activity during rapid eye movement sleep resembles waking activity. The basal forebrain also contains neurons that release gamma-aminobutyric acid. Some of these gamma-aminobutyric acid neurons are thought to promote sleep. Adenosine is a neuromodulator molecule that accumulates in the brain during wakefulness. Increased adenosine levels are associated with increased sleepiness. Caffeine works by blocking adenosine receptors in the brain. This is one reason why caffeine promotes wakefulness. The longer a person stays awake, the more adenosine accumulates. This creates increasing pressure to sleep that is sometimes called sleep debt. During sleep, adenosine levels decrease. This is thought to be one of the restorative functions of sleep. The two-process model of sleep regulation describes how sleep is controlled. One process is circadian and is driven by the suprachiasmatic nucleus of the hypothalamus. The other process in the two-process model is homeostatic. This refers to the buildup of sleep pressure during wakefulness and its dissipation during sleep. The interaction between circadian and homeostatic processes determines when a person feels sleepy and when a person feels alert. Both processes must be considered to understand sleep timing. The term hypnotic is used to describe drugs that induce sleep. It comes from the Greek word for sleep, hypnos. The term sedative refers to drugs that have a calming effect. Sedatives and hypnotics are often grouped together because many drugs have both properties. The distinction between sedation and sleep induction is sometimes a matter of dose. Higher doses of sedatives can induce sleep, and lower doses can produce calming effects. The term anxiolytic refers to drugs that reduce anxiety. Many sedative hypnotic drugs also have anxiolytic properties. Barbiturates were once commonly used as anxiolytics. They have largely been replaced by benzodiazepines and other drug classes for this purpose. The therapeutic index is a measure of drug safety. It compares the dose that produces a therapeutic effect to the dose that produces toxic effects. Barbiturates have a relatively narrow therapeutic index. The difference between an effective dose and a dangerous dose is relatively small. Benzodiazepines have a wider therapeutic index than barbiturates. This is one reason they were considered safer when they were introduced. Flumazenil is a drug that can reverse the effects of benzodiazepines. It works by blocking the benzodiazepine binding site on the gamma-aminobutyric acid A receptor. There is no equivalent reversal agent for barbiturates. This contributes to the greater risk associated with barbiturate overdose. The gamma-aminobutyric acid A receptor has multiple binding sites. Different drug classes bind to different sites on the same receptor. The benzodiazepine binding site is distinct from the site where gamma-aminobutyric acid itself binds. Benzodiazepines enhance the effect of gamma-aminobutyric acid without directly activating the receptor. Barbiturates bind to another site on the gamma-aminobutyric acid A receptor. At high doses, barbiturates can directly activate the receptor even without gamma-aminobutyric acid present. This ability to directly activate the receptor at high doses contributes to the danger of barbiturate overdose. It can lead to profound central nervous system depression. Z drugs bind to the same general region of the gamma-aminobutyric acid A receptor as benzodiazepines. They show selectivity for receptors containing the alpha-1 subunit. The gamma-aminobutyric acid A receptor is made up of 5 subunits. Different combinations of subunits produce receptors with different properties. Receptors containing the alpha-1 subunit are abundant in brain regions associated with sedation. This helps explain why Z drugs produce sedation with fewer other effects. Receptors containing the alpha-2 and alpha-3 subunits are associated with anxiety reduction. Benzodiazepines affect these receptors as well as alpha-1 containing receptors. The concept of receptor subtype selectivity has guided the development of newer sedative hypnotic drugs. The goal has been to produce desired effects while minimizing unwanted effects. Tolerance refers to a decrease in drug effect with repeated use. A person who develops tolerance may need higher doses to achieve the same effect. Tolerance can develop to the sedative effects of benzodiazepines. The rate at which tolerance develops varies among individuals. Physical dependence is a state in which the body has adapted to the presence of a drug. Stopping the drug suddenly can produce withdrawal symptoms. Withdrawal symptoms from benzodiazepines can include anxiety, insomnia, and in severe cases, seizures. Gradual dose reduction is typically recommended when discontinuing these drugs. Barbiturate withdrawal can be particularly severe. It was one of the first drug withdrawal syndromes recognized to be potentially life-threatening. Cross-tolerance can occur between drugs that act on the same receptor system. A person tolerant to one benzodiazepine may also be tolerant to others. Cross-tolerance also occurs between benzodiazepines and alcohol. Both substances affect gamma-aminobutyric acid receptors. The combination of benzodiazepines and alcohol can be particularly dangerous. Both substances depress the central nervous system, and their effects can add together. The combination of barbiturates and alcohol is similarly dangerous. Historically, this combination was involved in many accidental deaths. Methaqualone was a sedative hypnotic drug introduced in the 1960s. It was marketed as a safer alternative to barbiturates. methaqualone became widely misused and was eventually classified as a controlled substance. It is no longer legally available in most countries. The history of sedative hypnotic drugs includes several instances of drugs initially thought to be safe that later proved problematic. This pattern has influenced regulatory approaches to newer drugs. Meprobamate was an early sedative introduced in the 1950s. It was marketed under the brand name Miltown. Meprobamate was one of the first drugs to be heavily marketed directly to consumers. It became extremely popular in the United States during the 1950s. Like other early sedatives, meprobamate was later found to have significant potential for dependence. Its use declined after benzodiazepines became available. Glutathione was another sedative introduced as an alternative to barbiturates. It was marketed in the 1950s under the brand name Doriden. Glutathione was later recognized to have similar risks to barbiturates. It is no longer commonly used. Ethchlorvinol was a sedative hypnotic drug marketed under the brand name Placidil. It was known for its distinctive green color. It was used clinically from the 1950s through the 1980s. It has since been discontinued in most countries. The search for safer sedative hypnotic medications has been a recurring theme in pharmaceutical development. Each new generation has been introduced with claims of improved safety. Ramelteon was notable for being the first prescription sleep medication in more than 35 years to work through a novel mechanism involving melatonin receptor signaling rather than gamma-aminobutyric acid receptors. Because of this mechanism, Ramelteon does not produce the same type of next-day impairment associated with many gamma-aminobutyric acid receptor sedatives. The development of orexin receptor antagonists represented another new pharmacological approach to sleep medication. These drugs target the wake-promoting orexin system rather than enhancing inhibitory gamma-aminobutyric acid signaling. Suvorexant became the first orexin receptor antagonist approved by the United States Food and Drug Administration in August 2014. This occurred roughly 16 years after orexin was first discovered. Orexin receptor antagonists do not appear to produce the same pattern of dependence seen with older sedative hypnotic drugs such as benzodiazepines and Z drugs. Available clinical data suggest limited tolerance development, although long-term effects continue to be studied. Sleep inertia refers to the grogginess and impaired performance that can occur immediately after waking. It typically resolves within 15 to 30 minutes. Some sedative hypnotic medications can prolong or intensify this effect. This is sometimes described as next-day impairment or a hangover effect. The duration of a drug's effect depends partly on its pharmacokinetic half-life. Drugs with longer half-lives are more likely to produce next-day effects. In 2013, the United States Food and Drug Administration recommended lower doses of zolpidem for women after research showed that women eliminate zolpidem more slowly on average. This was one of the first instances of sex-specific dosing recommendations for a widely used medication. Complex sleep behaviors have been reported with sedative hypnotic medications. These include walking, eating, or driving while not fully awake. In 2019, new warnings about these behaviors were required for azopiclone, zaleplone, and zolpidem. These behaviors appear to be rare but can be serious. Their underlying neurobiology is not fully understood. Parasomnias are unusual behaviors or experiences that occur during sleep, such as sleepwalking, sleep talking, and sleep terrors. These can occur naturally without medication, although certain drugs may increase their likelihood in susceptible individuals. The relationship between sedative hypnotics and parasomnias remains an active area of clinical research. Rebound insomnia refers to worsened sleep that can occur after stopping a sleep medication. It is thought to result from neuroadaptation to the presence of the drug. This effect is usually temporary and tends to resolve within days to weeks. Gradual tapering may reduce its severity. Sleep architecture refers to the structure and pattern of sleep stages throughout the night. Different sedative hypnotic drugs can alter sleep architecture in different ways. Barbiturates are known to suppress rapid eye movement sleep. Benzodiazepines also reduce rapid eye movement sleep and may reduce slow wave sleep. Z drugs appear to have less impact on sleep architecture, although effects vary by compound and dose. Orexin receptor antagonists such as suvorexant, lemborexant, and daridorexant appear to preserve more normal sleep architecture compared to older drug classes. Relatively typical proportions of sleep stages have been observed in clinical studies. The clinical significance of medication-induced changes in sleep architecture is still being studied. Rapid eye movement sleep is associated with memory consolidation and emotional processing. Slow wave sleep is linked to physical restoration and immune function. When rapid eye movement sleep is suppressed, a rebound increase in this stage can occur after stopping medication. This can be accompanied by vivid or disturbing dreams. The electroencephalogram is a technique used to measure brain electrical activity during sleep. Each sleep stage produces characteristic patterns. Wakefulness shows low amplitude, high frequency brain waves. Drowsiness and light sleep show slower, larger amplitude waves. Stage 2 non-rapid eye movement sleep includes sleep spindles and K complexes. Slow wave sleep is characterized by delta waves. Rapid eye movement sleep shows brain wave patterns similar to wakefulness. This is why it is sometimes called paradoxical sleep. Polysomnography is a comprehensive sleep study that records multiple physiological signals. These include brain waves, eye movements, muscle activity, heart rate, and breathing patterns. It is used to diagnose sleep disorders such as insomnia, narcolepsy, and sleep apnea. The multiple sleep latency test measures how quickly a person falls asleep during daytime nap opportunities. A short sleep latency suggests increased physiological sleepiness. This test is commonly used in the diagnosis of narcolepsy and other hypersomnia disorders. The maintenance of wakefulness test measures how well a person can stay awake in a quiet, dimly lit environment. It is used to evaluate a person's ability to resist falling asleep, often in clinical or occupational settings where alertness is important. Actigraphy uses a small wrist-worn device to track movement over long periods, sometimes for days or weeks. By analyzing patterns of movement and stillness, researchers can estimate sleep and wake cycles in a person's natural environment. Actigraphy is less detailed than a full sleep study, but is useful for studying circadian rhythms and long-term sleep patterns outside the laboratory. Sleep research advanced rapidly in the 20th century with the development of electroencephalography, which allowed scientists to measure brain waves and identify different stages of sleep. In 1953, Eugene Aserinsky and Nathaniel Kleitman first described rapid eye movement sleep. This fundamentally changed how scientists understood sleep. Before this discovery, sleep was thought to be a single uniform state. Identifying distinct stages revealed sleep to be a complex structured biological process. Nathaniel Kleitman is often called the father of modern sleep research. He established the first dedicated sleep research laboratory in the United States and conducted pioneering studies on sleep deprivation and circadian rhythms. Some of his experiments involved living in caves to study biological rhythms without external time cues. Sleep research expanded significantly in the second half of the 20th century. Specialized sleep disorders centers began appearing in the 1970s. The American Academy of Sleep Medicine was founded in 1975 and helped establish clinical standards for diagnosing and treating sleep disorders. Sleep medicine became a recognized medical specialty in the United States in 1996. Physicians can now receive board certification in sleep medicine. The discovery of Orexin in 1998 was described as one of the most important advances in sleep research since the discovery of rapid eye movement sleep. Orexin provided a molecular explanation for narcolepsy, a disorder characterized by excessive daytime sleepiness and sudden episodes of muscle weakness called cataplexy. Cataplexy is often triggered by strong emotions. Type 1 narcolepsy is associated with low orexin levels in cerebrospinal fluid, which can be measured through specialized testing. Type 2 narcolepsy involves excessive sleepiness without cataplexy, and orexin levels are usually normal. Narcolepsy affects roughly 1 in 2,000 people and often begins in adolescence or young adulthood, though it can occur at any age. Diagnosis is frequently delayed for many years because symptoms are often misunderstood. Before orexin was discovered, the cause of narcolepsy was unknown. Animal models existed, including a colony of narcoleptic dogs maintained at Stanford University. These dogs were found to have inherited mutations in the orexin receptor gene, which helped establish the biological link between orexin and narcolepsy. Thomas Kilduff helped direct the narcoleptic dog research program and later became one of the co-discoverers of hypocretin, another name for orexin. The discovery of orexin and hypocretin happened independently by two research teams at nearly the same time, an example of simultaneous scientific discovery. Luis de Lechea's team was searching for genes expressed in the hypothalamus. Masashi Yanagisawa's team was searching for ligands for orphan receptors, receptors whose natural signaling molecules were unknown. The orexin system is now known to influence many functions beyond sleep, including feeding behavior, reward processing, and stress responses. Orexin neurons integrate information about energy status and stress and send signals throughout the brain and spinal cord. This allows them to influence many physiological systems. Orexin neurons are located in the lateral hypothalamus, an area historically known as a feeding center. Damage to this region in animals caused them to stop eating. The discovery of orexin neurons in this region helped link feeding and arousal. Fasting increases orexin activity, which may explain why hunger can promote wakefulness. Glucose can inhibit orexin neurons, which may contribute to drowsiness after eating. Sleep and metabolism influence each other in complex ways. Sleep deprivation has been associated with changes in appetite-regulating hormones. Leptin, which signals fullness, tends to decrease with sleep deprivation, while ghrelin, which stimulates appetite, tends to increase. These hormonal shifts may help explain why insufficient sleep is associated with increased appetite, though many factors are involved. The glymphatic system is a recently described system that helps clear waste products from the brain and is most active during sleep, especially slow-wave sleep. It uses cerebrospinal fluid to flush metabolic waste from brain tissue, providing insight into the restorative role of sleep. One waste product of interest is beta amyloid, a protein that accumulates in Alzheimer's disease. Animal studies suggest that sleep increases beta amyloid clearance, and sleep disturbances are common in people with Alzheimer's disease. Whether improving sleep can reduce the risk of neurodegeneration is still under investigation. The pineal gland was one of the last brain structures to be understood, and its function remained mysterious for centuries. In 1958, Aaron Lerner isolated melatonin from bovine pineal glands and named it based on its effects on melanin-containing cells. This discovery opened the field of melatonin research. Melatonin is synthesized from serotonin through a two-step enzymatic process, and the pineal gland contains the enzymes required for this conversion. Light exposure suppresses melatonin production by inhibiting these enzymes, which is one mechanism by which light influences circadian timing and sleep-wake rhythms. The pathway from the eyes to the pineal gland involves multiple brain structures. Light information travels from the retina to the suprachiasmatic nucleus and then through additional neural pathways to reach the pineal gland. The superior cervical ganglion is the final relay before the pineal gland. Nerve fibers from this ganglion release norepinephrine, also called noradrenaline, onto pineal gland cells. Norepinephrine stimulates the pineal gland to produce melatonin during darkness because norepinephrine release increases when light input to the suprachiasmatic nucleus decreases. Blue light is particularly effective at suppressing melatonin production. The photoreceptors that detect light for circadian purposes are most sensitive to blue wavelengths. These specialized photoreceptors are called intrinsically photosensitive retinal ganglion cells. They contain a light-sensitive pigment called melanopsin. Intrinsically photosensitive retinal ganglion cells were discovered in 2002. Their discovery explained how blind individuals can sometimes maintain circadian rhythms. The rods and cones used for vision are different from the cells used for circadian light detection. This explains why some blind individuals still respond to light for circadian purposes. Shift work can disrupt circadian rhythms because it requires people to be awake when their internal clock promotes sleep. This misalignment can affect health and performance. Jet lag occurs when travel across time zones causes a mismatch between internal circadian time and local time. The body's clock takes time to adjust to the new schedule. The rate of circadian adjustment is typically about 1 hour per day. Crossing many time zones can result in several days of jet lag symptoms. Eastward travel is generally more difficult to adjust to than westward travel. Advancing the circadian clock is harder than delaying it. The circadian clock tends to run slightly longer than 24 hours. This makes it easier to stay up later than to go to sleep earlier. This asymmetry affects adjustment to schedule changes. Delayed sleep phase disorder is a circadian rhythm disorder in which the internal clock is shifted later than desired. People with this condition have difficulty falling asleep at conventional times. Advanced sleep phase disorder is the opposite pattern, with the internal clock shifted earlier. People with this condition become sleepy in the early evening and wake very early in the morning. Delayed sleep phase disorder is more common in adolescents and young adults. Advanced sleep phase disorder is more common in older adults. The natural shift toward later sleep times during adolescence is well documented. This biological tendency can conflict with early school start times. Light therapy involves exposure to bright light at specific times to shift circadian rhythms. Morning light exposure can help advance the circadian clock. Evening light exposure can help delay the circadian clock. The timing of light exposure determines the direction of circadian shift. Light boxes used for light therapy typically produce 10,000 lux of illumination. This is much brighter than typical indoor lighting, but dimmer than direct sunlight. The duration of light exposure needed for circadian effects is typically 30 minutes to 2 hours. Effects depend on timing, intensity, and duration. Dim light melatonin onset is a marker used to assess circadian timing. It measures when melatonin begins to rise in the evening under dim light conditions. Measuring dim light melatonin onset requires collecting saliva or blood samples at regular intervals during the evening. It is primarily used in research settings. Core body temperature also follows a circadian rhythm. Temperature is lowest in the early morning hours and highest in the late afternoon or early evening. The circadian low point in body temperature typically occurs about 2 hours before habitual wake time. This point is sometimes called the temperature nadir. Alertness tends to be lowest around the time of the temperature nadir. This is one reason accidents are more common in the early morning hours. There is often a dip in alertness in the early to mid-afternoon. This is sometimes called the post-lunch dip, though it occurs even without eating lunch. The post-lunch dip reflects a circadian influence on alertness. It corresponds to a time when sleep propensity is relatively high. In many cultures, an afternoon nap or siesta is traditional. This practice aligns with the natural circadian dip in alertness. Napping can provide restorative benefits, but may interfere with nighttime sleep if taken too late in the day. The timing and duration of naps affect their consequences. Short naps of 20 to 30 minutes are generally less likely to cause sleep inertia upon waking. Longer naps may involve deeper sleep stages and more grogginess upon waking. Caffeine naps involve consuming caffeine immediately before a short nap. The caffeine takes effect as the person wakes, potentially reducing sleep inertia. The concept of sleep hygiene refers to behaviors and environmental factors that promote good sleep. These include consistent sleep schedules and a comfortable sleep environment. Cognitive behavioral therapy for insomnia is a structured program that addresses thoughts and behaviors affecting sleep. It is considered a first-line approach for chronic insomnia. Cognitive behavioral therapy for insomnia includes components such as sleep restriction, stimulus control, and cognitive restructuring. It typically involves multiple sessions with a trained provider. Sleep restriction involves limiting time in bed to match actual sleep time. This can temporarily increase sleepiness, but often improves sleep efficiency. Stimulus control involves strengthening the association between the bed and sleep. This includes using the bed only for sleep and leaving the bed when unable to sleep. Cognitive restructuring addresses unhelpful thoughts about sleep. Worry about sleep can interfere with sleep and create a cycle. Studies have found that cognitive behavioral therapy for insomnia produces improvements comparable to sleep medications. The effects may be more durable than medication effects. Access to cognitive behavioral therapy for insomnia has historically been limited. Digital versions delivered through apps or websites are being developed to increase access. The relationship between sleep and mental health is bidirectional. Sleep problems can contribute to mental health conditions. Mental health conditions often involve sleep disturbances. Insomnia is a common symptom of depression and can also increase the risk of developing depression. Anxiety disorders are frequently associated with difficulty falling asleep. Racing thoughts and worry can interfere with the transition to sleep. Post-traumatic stress disorder often involves nightmares and sleep disturbances. These sleep problems can contribute to daytime symptoms. Bipolar disorder involves changes in sleep patterns during mood episodes. Reduced need for sleep is characteristic of manic episodes. Schizophrenia is often associated with disrupted circadian rhythms and sleep patterns. Sleep disturbances may precede or accompany psychotic symptoms. The relationship between sleep and pain is also bidirectional. Pain can disrupt sleep, and poor sleep can increase pain sensitivity. Sleep disturbances are common in chronic pain conditions. Improving sleep may be one component of pain management. Fibromyalgia is a chronic pain condition frequently associated with sleep problems. Non-restorative sleep is one of the diagnostic criteria for this condition. Alpha-delta sleep is an abnormal sleep pattern observed in some people with fibromyalgia. It involves intrusion of waking brainwave patterns into deep sleep. Sleep apnea is a sleep disorder characterized by repeated pauses in breathing during sleep. These pauses can fragment sleep and reduce oxygen levels. Studies have found that cognitive behavioral therapy for insomnia produces improvements comparable to sleep medications. The effects may be more durable than medication effects. Access to cognitive behavioral therapy for insomnia has historically been limited. Digital versions delivered through apps or websites are being developed to increase access. The relationship between sleep and mental health is bidirectional. Sleep problems can contribute to mental health conditions. Mental health conditions often involve sleep disturbances. Insomnia is a common symptom of depression and can also increase the risk of developing depression. Anxiety disorders are frequently associated with difficulty falling asleep. Racing thoughts and worry can interfere with the transition to sleep. Post-traumatic stress disorder often involves nightmares and sleep disturbances. These sleep problems can contribute to daytime symptoms. Bipolar disorder involves changes in sleep patterns during mood episodes. Reduced need for sleep is characteristic of manic episodes. Schizophrenia is often associated with disrupted circadian rhythms and sleep patterns. Sleep disturbances may precede or accompany psychotic symptoms. The relationship between sleep and pain is also bidirectional. Pain can disrupt sleep, and poor sleep can increase pain sensitivity. Sleep disturbances are common in chronic pain conditions. Improving sleep may be one component of pain management. Fibromyalgia is a chronic pain condition frequently associated with sleep problems. Non-restorative sleep is one of the diagnostic criteria for this condition. Alpha-delta sleep is an abnormal sleep pattern observed in some people with fibromyalgia. It involves intrusion of waking brainwave patterns into deep sleep. Sleep apnea is a sleep disorder characterized by repeated pauses in breathing during sleep. These pauses can fragment sleep and reduce oxygen levels. Obstructive sleep apnea is the most common form of sleep apnea and occurs when the airway becomes blocked during sleep, typically due to relaxation of throat muscles in the upper airway. Central sleep apnea involves failure of the brainstem respiratory centers to send appropriate signals to breathing muscles and is less common than obstructive sleep apnea. Risk factors for obstructive sleep apnea include obesity, male sex, and older age, though it can also occur in people without these risk factors. Snoring is common in obstructive sleep apnea, but is not sufficient for diagnosis, as many people snore without having sleep apnea. Continuous positive airway pressure is a common treatment for obstructive sleep apnea and involves wearing a mask that delivers pressurized air to keep the airway open. Restless leg syndrome is a condition characterized by uncomfortable sensations in the legs and an urge to move them, with symptoms typically worsening in the evening and at night. Restless leg syndrome can significantly interfere with sleep onset because the urge to move the legs makes it difficult to remain still and fall asleep. Periodic limb movement disorder involves repetitive limb movements during sleep, and these movements can cause brief arousals that fragment sleep. Restless leg syndrome and periodic limb movement disorder often occur together, though they are considered separate conditions. Iron deficiency has been associated with restless leg syndrome, and some people with this condition benefit from iron supplementation. Dopamine pathways in the brain appear to be involved in restless leg syndrome, and medications that affect dopamine signaling can be helpful for some people with this condition. Rapid eye movement sleep behavior disorder involves loss of the normal muscle paralysis, also called atonia, during rapid eye movement sleep. People with this condition may act out their dreams. Rapid eye movement sleep behavior disorder can result in injury to the person or their bed partner. And dream enactment can involve punching, kicking, or falling out of bed. Rapid eye movement sleep behavior disorder has been associated with later development of certain neurodegenerative diseases, and this association is an area of active research. Parkinson's disease and Lewy body dementia are among the conditions associated with rapid eye movement sleep behavior disorder. The sleep disorder may precede other symptoms by many years. Sleepwalking is a parasomnia that occurs during non-rapid eye movement sleep and is most common in children, though it can occur in adults. Sleepwalking episodes typically occur during the first third of the night, when slow-wave sleep is most abundant. During sleepwalking, the person may appear awake, but is actually in a mixed state of sleep and wakefulness, and typically has no memory of the episode. Sleep terrors are another non-rapid eye movement parasomnia and involve sudden arousal with intense fear, screaming, and activation of the sympathetic nervous system. Sleep terrors are different from nightmares, as nightmares occur during rapid eye movement sleep and are usually remembered, while sleep terrors occur during non-rapid eye movement sleep and are typically not remembered. Confusional arousals involve waking in a confused state, often with disorientation and slow responses, and are most common in children. Sleep-related eating disorder involves eating during partial arousals from sleep, and people with this condition may have no memory of eating. Sleep paralysis is a temporary inability to move that occurs when falling asleep or waking up, and represents an intrusion of rapid eye movement sleep atonia into wakefulness. Sleep paralysis can be frightening, but is generally harmless and typically lasts only seconds to minutes. Hypnagogic hallucinations occur during the transition from wakefulness to sleep, while hypnopompic hallucinations occur during the transition from sleep to wakefulness. These hallucinations during sleep transitions can involve visual, auditory, or tactile experiences and are relatively common. They do not necessarily indicate a sleep disorder. Exploding head syndrome is a sleep-related sensory phenomenon that involves the perception of a loud noise or explosion when falling asleep or waking up. Despite its dramatic name, exploding head syndrome is not dangerous. The perceived sound is not real and does not indicate any physical problem. Sleep bruxism involves grinding or clenching the teeth during sleep and can cause dental damage and jaw pain. Sleep-related leg cramps are painful muscle contractions that occur during sleep and typically affect the calf muscles and can disrupt sleep. The causes of sleep-related leg cramps are not fully understood, and they become more common with age. Kleine-Levin syndrome is a rare sleep disorder characterized by recurring episodes of excessive sleep, during which individuals may sleep up to 20 hours per day. Kleine-Levin syndrome primarily affects adolescent males, and episodes can last days to weeks and are separated by periods of normal sleep. During Kleine-Levin episodes, affected individuals may also experience changes in behavior, cognition, and appetite, and the cause of this syndrome is unknown. Idiopathic hypersomnia is a sleep disorder characterized by excessive daytime sleepiness without the other features of narcolepsy. The cause is unknown, which is what idiopathic means. People with idiopathic hypersomnia often have difficulty waking up and may experience prolonged sleep inertia. They may sleep long hours but still feel unrefreshed. Insufficient sleep syndrome is a condition in which a person does not obtain enough sleep to support normal alertness and is caused by behavioral choices rather than a medical condition. Insufficient sleep syndrome is diagnosed when sleepiness resolves with extended sleep. Many people in modern society may be chronically sleep deprived without realizing it. The amount of sleep needed varies among individuals. Most adults need 7 to 9 hours per night, though some need more or less. Short sleepers are individuals who naturally need less sleep than average and function well on 6 hours or less without apparent negative effects. True short sleepers are rare, and many people who believe they need little sleep are actually chronically sleep deprived. Long sleepers are individuals who naturally need more sleep than average and may need 10 hours or more to feel fully rested. Sleep need is influenced by genetic factors, and studies of twins have shown that sleep duration and sleep patterns have heritable components. Specific genes have been identified that influence sleep duration and other sleep characteristics, and research in this area continues to identify new genetic factors. The DEC2 gene, also called the basic helix loop helix family member E41 gene, mutation is associated with short sleep duration, and people with this mutation may need less sleep than average. Sleep patterns change across the lifespan, and newborns sleep up to 17 hours per day in multiple short periods. Sleep becomes consolidated into a single nighttime period during early childhood, and daytime naps gradually decrease and then disappear in most children. Adolescents experience a biological shift toward later sleep timing, driven by changes in circadian rhythm regulation during puberty. Sleep duration tends to decrease slightly with age and adulthood, and older adults often experience more fragmented sleep and less slow-wave sleep. The suprachiasmatic nucleus may become less responsive to light with age, and this could contribute to circadian rhythm changes in older adults. Early morning awakening is common in older adults, and this pattern may reflect an advance in circadian timing. The perception that older adults need less sleep may be inaccurate, as sleep need may remain stable while the ability to obtain consolidated sleep often decreases. Sleep disorders become more common with age, and conditions such as sleep apnea and restless leg syndrome increase in prevalence in older populations. Many medications can affect sleep, with some promoting wakefulness and others causing drowsiness. Beta blockers are a class of cardiovascular medications that can affect sleep. Some people experience sleep disturbances or vivid dreams while taking these medications. Corticosteroids can cause insomnia in some people, and this effect is related to their impact on hormonal systems. Some antidepressants can cause insomnia, while others promote drowsiness, and the effect depends on the specific medication and the individual. Selective serotonin reuptake inhibitors can affect rapid eye movement sleep, and some people experience changes in dreaming while taking these medications. Tricyclic antidepressants tend to have sedating effects and were sometimes used to promote sleep before newer medications became available. Trazodone is an antidepressant that is commonly used at low doses for sleep, and its sedating properties have led to widespread off-label use for insomnia. Mirtazapine is another antidepressant with sedating properties and is sometimes chosen for people with depression who also have insomnia. Antihistamines used for sleep include diphenhydramine and doxylamine, which are the active ingredients in many over-the-counter sleep aids. The sedating effects of older antihistamines are considered a side effect in allergy treatment, but a desired effect in sleep aids, and the same compounds are marketed for different purposes. Alcohol is sometimes used as a sleep aid, but it generally impairs sleep quality. It may help with sleep onset, but disrupts sleep later in the night. Alcohol suppresses rapid eye movement sleep in the first part of the night, and as alcohol is metabolized, rapid eye movement sleep rebounds, often with vivid dreams. Alcohol also relaxes throat muscles, which can worsen snoring and sleep apnea, and people with sleep-disordered breathing may be particularly sensitive to alcohol's effects. Cannabis has been used by some people to promote sleep, though research on its effects on sleep is still limited and results have been mixed. Some components of cannabis may promote sleep, while others may interfere with it, and the effects appear to depend on the specific compounds and doses. Regular cannabis use may lead to tolerance to its sleep-promoting effects, and withdrawal from regular use can cause sleep disturbances. Valerian is an herbal supplement sometimes used for sleep, and scientific evidence for its effectiveness is limited and inconsistent. Chamomile tea is traditionally used to promote relaxation and sleep, and studies on its sleep effects have shown modest or inconsistent results. Lavender aromatherapy has been studied for sleep promotion, and some studies have reported modest improvements in sleep quality. Magnesium supplementation has been explored for sleep improvement, and some studies suggest possible benefits, particularly in people with low magnesium levels. Glycine is an amino acid that has been studied for sleep effects, and some research suggests it may improve subjective sleep quality. L-theanine is a compound found in tea that has been studied for relaxation and sleep, and may promote relaxation without causing drowsiness. The dietary supplement market for sleep products is large and growing, and many products contain combinations of herbs, amino acids, and other compounds. Dietary supplements are regulated differently than prescription medications and do not require the same level of evidence for safety and effectiveness before being sold. Melatonin is available as a dietary supplement in many countries, including the United States, while in some other countries it is available only by prescription. The dose of melatonin in supplements varies widely, and amounts typically range from less than 1 milligram to 10 milligrams or more. Research suggests that lower doses of melatonin may be sufficient for circadian effects, and higher doses do not necessarily produce greater benefits. The timing of melatonin administration may be more important than the dose for circadian effects, and taking melatonin at the wrong time can shift circadian rhythms in undesired directions. Extended-release melatonin formulations have been developed to maintain blood levels throughout the night, and these may have different effects than immediate-release forms. Prolonged-release melatonin is approved as a prescription medication in some countries and is marketed for insomnia in people over 55 years of age in Europe. The quality of over-the-counter melatonin supplements can vary, and studies have found that actual melatonin content sometimes differs from what is stated on the label. Some melatonin supplements have been found to contain serotonin as a contaminant, raising concerns about quality control in supplement manufacturing. The long-term safety of melatonin supplementation has not been fully established, and most studies have examined short-term use. Melatonin interacts with other hormonal systems in the body, and its effects on reproductive hormones and other systems are areas of ongoing research. Children's use of melatonin has increased substantially in recent years, and long-term effects of melatonin use in developing children are not well understood. Melatonin may be helpful for children with certain neurodevelopmental conditions who have sleep difficulties, and it is sometimes used in this population under medical supervision. The production of melatonin by the pineal gland decreases with age, which has led to interest in melatonin supplementation for older adults. Whether the age-related decline in melatonin contributes to sleep changes in older adults is not established, and the relationship between melatonin levels and sleep quality is complex. Light exposure at night, particularly from electronic devices, can suppress melatonin production, and this has raised concerns about the effects of modern lighting on sleep. Blue light filtering glasses and screen settings have been developed to reduce blue light exposure in the evening, and evidence for their effects on sleep is still accumulating. The term sleep debt refers to the cumulative effect of not getting enough sleep, and it suggests that lost sleep accumulates and must eventually be repaid. Whether sleep debt can truly be repaid with extra sleep is debated, and some effects of sleep loss may not be fully reversible with recovery sleep. Chronic sleep restriction has been associated with various health risks in observational studies, including cardiovascular disease, metabolic disorders, and impaired immune function. The relationship between sleep duration and mortality follows a U-shaped curve in many studies, with both very short and very long sleep durations associated with increased mortality risk. Whether long sleep duration directly causes harm or is a marker of underlying health problems is unclear, and this association is still being investigated. Sleep is essential for memory consolidation, and different types of memory appear to benefit from different sleep stages. Declarative memory, which involves facts and events, appears to benefit from slow-wave sleep, while procedural memory, which involves skills and procedures, may benefit from rapid eye movement sleep. Sleep spindles during stage 2 of non-rapid eye movement sleep have been associated with memory consolidation, and research suggests they may help transfer information from short-term to long-term storage. The hippocampus is a brain structure important for memory formation, and during sleep it appears to replay experiences from the day. This replay of memories during sleep may help strengthen important memories and integrate them with existing knowledge, and the process occurs without conscious awareness. Sleep before learning helps prepare the brain to acquire new information, and sleep deprivation can impair the ability to form new memories. Sleep after learning helps consolidate what was learned, and studying before sleep may be more effective than studying at other times for some types of material. Naps can also benefit memory consolidation, and even short naps may help stabilize newly learned information. Emotional memories appear to be preferentially consolidated during sleep, and sleep may help process emotional experiences. Rapid eye movement sleep has been associated with emotional memory processing, and dreams during this stage often have emotional content. The function of dreaming remains a subject of scientific debate, and various theories have been proposed, though none is universally accepted. One theory suggests that dreams help process emotions and experiences, while another theory proposes that dreams result from random brain activity during sleep, with the brain creating narratives from meaningless neural signals. Some researchers suggest that dreaming may serve a problem-solving function, and anecdotal reports describe creative insights occurring during dreams. The activation synthesis hypothesis proposes that dreams are the brain's attempt to make sense of random neural activity, and this theory was influential in the late 20th century. More recent theories emphasize the role of dreaming in memory consolidation and emotional regulation, and draw on neuroscience research. Lucid dreaming is a state in which the dreamer becomes aware that they are dreaming, and some lucid dreamers can control aspects of their dreams. Lucid dreaming occurs most often during rapid eye movement sleep and has been verified through studies using eye movement signals. Techniques have been developed to increase the likelihood of lucid dreaming, including reality testing and wake-back-to-bed methods. Research on lucid dreaming has provided insights into consciousness and the nature of the dreaming brain, and it remains an active area of scientific investigation. Dream content varies across cultures but also shows universal themes, and common dreams include falling, being chased, and appearing in public inappropriately dressed. Nightmares are disturbing dreams that usually cause awakening and are most common in children but can occur at any age. Frequent nightmares can be distressing and may warrant clinical attention, and nightmare disorder is recognized as a sleep-wake disorder. Image rehearsal therapy is a treatment for chronic nightmares and involves mentally rehearsing changed versions of recurring nightmares during wakefulness. Post-traumatic nightmares are common after traumatic experiences and often involve themes related to the traumatic event. Prazosin is a blood pressure medication that has been studied for post-traumatic nightmares, and research results have been mixed. The relationship between sleep and the immune system is bidirectional, with sleep affecting immune function and immune activation affecting sleep. Sleep deprivation has been associated with reduced immune function in experimental studies, and people who sleep less may be more susceptible to infections. Infection typically increases sleep, and this response is thought to support immune function during illness. Cytokines are immune signaling molecules that can promote sleep, and their release during infection contributes to increased sleepiness. Interleukin-1 and tumor necrosis factor are cytokines that have been shown to promote sleep and are part of the inflammatory response. Chronic inflammation has been associated with sleep disturbances, and the relationship between sleep and inflammation is complex. Sleep is important for vaccine responses, and studies have shown that sleep deprivation can reduce antibody responses to vaccination. Growth hormone is released primarily during slow-wave sleep, which is one reason why adequate sleep is important for development in children. Cortisol follows a circadian rhythm with the levels lowest around midnight and the highest in the early morning. This rhythm helps prepare the body for waking activity. Sleep deprivation can disrupt the normal cortisol rhythm, and elevated evening cortisol has been observed after sleep restriction. Thyroid-stimulating hormone levels increase during sleep, and sleep deprivation can alter thyroid hormone patterns. Prolactin levels increase during sleep and has various functions including supporting immune function. Testosterone levels follow a circadian pattern and are influenced by sleep, and sleep deprivation can reduce testosterone levels in men. The autonomic nervous system undergoes changes during sleep, and heart rate and blood pressure typically decrease during non-rapid eye movement sleep. During rapid eye movement sleep, autonomic activity becomes more variable, and heart rate and blood pressure can fluctuate considerably. Blood pressure normally decreases during sleep, a phenomenon called nocturnal dipping. Absence of this dipping has been associated with cardiovascular risk. Sleep-disordered breathing can cause repeated increases in blood pressure during the night, which may contribute to cardiovascular problems over time. The relationship between sleep and cardiovascular health is an active area of research, and both short and long sleep duration have been associated with cardiovascular risk. Glucose metabolism is affected by sleep, and sleep deprivation can reduce insulin sensitivity. Chronic short sleep has been associated with increased risk of type 2 diabetes in epidemiological studies, and the relationship may be mediated by effects on metabolism and appetite. Sleep restriction can increase appetite, particularly for high-calorie foods, and this may contribute to weight gain in people who do not get enough sleep. The gut microbiome may be affected by sleep patterns, and emerging research suggests bidirectional relationships between gut bacteria and sleep. body temperature regulation changes during sleep, and the body's set point for temperature decreases during sleep. A cool sleeping environment may facilitate sleep onset, and the decrease in core body temperature is part of the transition to sleep. Hot environments can disrupt sleep, and difficulty dissipating heat can interfere with the normal temperature changes during sleep. The thermoneutral zone is the range of environmental temperatures at which the body can maintain its temperature without extra energy expenditure. Sleeping environments within this zone may promote better sleep. Weighted blankets have become popular as sleep aids, and some studies suggest they may reduce anxiety and improve sleep in certain populations. The sensation of deep pressure from weighted blankets is thought to have calming effects, similar to deep pressure therapy used in occupational therapy. White noise machines and apps produce constant background sound, and some people find this helpful for masking disruptive environmental noises. Pink noise has more energy at lower frequencies than white noise, and some research suggests it may benefit sleep and memory. Sleep position can affect sleep quality and health, and side sleeping is generally recommended for people with obstructive sleep apnea or snoring. Sleeping on the back can worsen obstructive sleep apnea in some people because gravity can cause the tongue and soft tissues of the upper airway to obstruct the airway. Positional therapy involves training people to sleep in positions that reduce obstructive sleep apnea, and various devices have been developed for this purpose. Pillow height and firmness affect neck alignment and comfort during sleep, and the optimal pillow varies by sleep position. Mattress characteristics influence sleep comfort, though the best mattress type varies among individuals. The sleep environment is often described as needing to be dark for optimal sleep, and even small amounts of light can affect melatonin production and sleep quality. Blackout curtains or eye masks can help create a dark sleep environment, and this may be useful for shift workers who sleep during daylight hours. Noise can disrupt sleep even without full awakenings, and the brain continues to process sounds during sleep. Earplugs can reduce noise exposure during sleep, though some people find them uncomfortable or worry about missing important sounds. Recommended bedroom temperature for sleep is typically described as being between 60 and 67 degrees Fahrenheit, though individual preferences vary. Bed partners can affect each other's sleep through movement, snoring, or differing schedules. Some couples choose separate beds or bedrooms to improve sleep, and this practice is more common than often acknowledged. Pets in the bedroom can disrupt sleep for some people, while others find pets comforting and report no sleep problems. Exercise timing affects sleep, and regular exercise is generally associated with better sleep, though vigorous exercise near bedtime may be stimulating for some people. Morning light exposure, combined with physical activity, may help strengthen circadian rhythms regulated by the suprachiasmatic nucleus. This combination is sometimes recommended for circadian rhythm disorders. Eating close to bedtime can affect sleep, as large meals may cause discomfort and certain foods may influence sleep quality. Caffeine has a half-life of approximately 5 to 6 hours in most adults, meaning half of the caffeine from a cup of coffee remains in the body after that time. Sensitivity to caffeine varies widely among individuals, and genetic differences in caffeine metabolism contribute to this variation. Some people tolerate evening caffeine without noticeable sleep effects, while others are sensitive enough that morning caffeine affects sleep. Caffeine blocks adenosine receptors in the brain and reduces sleepiness, while adenosine continues to accumulate, which can cause fatigue when caffeine wears off. Regular caffeine use leads to tolerance and physical dependence, and withdrawal symptoms can include headache, fatigue, and difficulty concentrating. Caffeine withdrawal typically begins 12 to 24 hours after the last dose and resolves within days to a week. Nicotine is a stimulant that can interfere with sleep, and smokers often have more difficulty falling asleep and experience more fragmented sleep. Nicotine withdrawal during the night can cause awakenings in smokers, particularly in the second half of the night. People who quit smoking may experience temporary sleep disturbances, and sleep typically improves after withdrawal resolves. Medication timing affects sleep, and some medications are best taken in the morning while others are better taken at bedtime. Diuretics taken near bedtime can cause nighttime urination, and taking them earlier in the day may reduce this problem. Some asthma medications can cause insomnia, especially beta-agonist bronchodilators such as albuterol. Stimulant medications for attention deficit hyperactivity disorder, including methylphenidate and amphetamines, can interfere with sleep, and timing and dosing adjustments may help. Decongestants containing pseudoephedrine can cause insomnia and are structurally similar to amphetamines. Some herbal supplements contain stimulants and can interfere with sleep, and products with caffeine or guarana are often described as needing to be avoided near bedtime. Ginseng has stimulant properties and may interfere with sleep, and it is included in many energy products and supplements. Drug interactions can affect sleep medications, and some combinations can increase sedation to dangerous levels. Opioids combined with benzodiazepines significantly increase the risk of respiratory depression and have been the subject of regulatory warnings from agencies such as the United States Food and Drug Administration. Alcohol combined with sleep medications can be dangerous due to additive sedative effects. Grapefruit juice can affect the metabolism of many medications, including some sleep drugs, by inhibiting liver enzymes in the cytochrome P450 system. The cytochrome P450 system is a family of liver enzymes that metabolize many drugs, and variations contribute to individual differences in drug response. Rapid metabolizers clear certain drugs faster than average, which can reduce drug effectiveness. Slow metabolizers may have higher drug levels and longer-lasting effects, increasing both benefits and side effects. Genetic testing for drug metabolism enzymes can help predict how individuals respond to certain medications. Age affects drug metabolism, and older adults often metabolize drugs more slowly, affecting dosing requirements. Liver disease can impair drug metabolism, requiring lower doses of many medications. Kidney function affects drug elimination, and reduced kidney function can lead to drug accumulation. Body composition affects drug distribution, and fat-soluble drugs may have prolonged effects in individuals with higher body fat. Pregnancy alters drug metabolism and distribution in complex ways, and sleep medications are generally used cautiously during pregnancy. Most sleep medications cross the placenta, and their effects on the developing fetus depend on the drug and timing of exposure. Many sleep medications are excreted in breast milk, which is an important consideration for breastfeeding mothers. Some countries use letter categories to classify drug safety in pregnancy, and these categories reflect the level of evidence for risk during pregnancy. Sleep problems are common during pregnancy. Hormonal changes, physical discomfort, and frequent urination all contribute to disrupted sleep. Restless leg syndrome often worsens during pregnancy and typically improves after delivery. Sleep apnea can develop or worsen during pregnancy due to weight gain and hormonal changes. Sleep position becomes important in late pregnancy, and side sleeping is generally recommended to optimize blood flow to the placenta. Postpartum sleep is often fragmented due to infant care needs, which can be physically and emotionally challenging. Postpartum depression is associated with sleep disturbances, and the relationship between sleep and mood during this period is complex. Infant sleep patterns differ substantially from adult patterns. Newborns do not have consolidated nighttime sleep. Circadian rhythms in infants develop over several months, and before this development, sleep is distributed throughout day and night. Rapid eye movement sleep makes up a larger proportion of sleep in infants than in adults, and this proportion decreases with age. The The function of high rapid eye movement sleep in early life is not fully understood, but it may support brain development. Active sleep in infants is a developmental precursor of rapid eye movement sleep and involves movement and irregular breathing. Quiet sleep in infants corresponds to non-rapid eye movement sleep and involves less movement and more regular breathing. Sleep consolidation often begins around 3 to 4 months of age, as infants begin sleeping longer stretches at night. Cultural practices around infant sleep vary widely. Bed sharing is common in some cultures but discouraged in others for safety reasons. Safe sleep guidelines recommend a firm, flat sleep surface for infants to reduce the risk of sudden infant death syndrome, also known as SIDS. Back sleeping is recommended for infants and has significantly reduced sudden infant death syndrome rates. Toddlers typically need 11 to 14 hours of sleep per day, including naps. Sleep needs decrease gradually through childhood. Naps usually phase out between ages 3 and 5, though some children stop earlier or continue longer. School-age children generally need 9 to 11 hours of sleep per night, but many do not achieve this. Bedtime resistance is common in young children, and consistent bedtime routines can help establish healthy sleep habits. Nighttime fears are common in preschool and early school-age children and usually decrease with reassurance and age. Sleepwalking and sleep terrors are most common in childhood and typically decrease during adolescence. Sleep-disordered breathing in children often differs from adults, and enlarged tonsils and adenoids are common contributors. Adenotonsillectomy can improve sleep-disordered breathing in many children and is a common treatment for pediatric obstructive sleep apnea. Sleep problems in children can affect behavior and academic performance and may resemble attention deficit hyperactivity disorder, often abbreviated as ADHD. The relationship between sleep and ADHD is complex because sleep deprivation can mimic symptoms, and the disorder often involves sleep problems. Screen use before bedtime has been associated with sleep problems in children. Light exposure and stimulating content may both contribute. The American Academy of Pediatrics recommends avoiding screens in the hour before bedtime. Adolescents typically need 8 to 10 hours of sleep per night, but most get less than this. Early school start times conflict with the adolescent biological shift toward later sleep timing, which has prompted calls for later start times. Some school districts have adopted later high school start times, with reported improvements in sleep, attendance, and academic performance. Adolescents often have different weekend and weekday sleep schedules, leading to social jet lag. Social jet lag refers to misalignment between social schedules and biological rhythms and is common when work or school schedules conflict with natural sleep timing. Shift workers are at high risk for circadian disruption because they must sleep when their biology promotes wakefulness. Rotating shift schedules are particularly challenging because the body cannot fully adapt before the schedule changes again. Forward rotation of shifts from days to evenings to nights is generally easier to adapt to than backward rotation. Strategic use of light and darkness can help shift workers adapt. Bright light during shifts and darkness during sleep periods can be beneficial. Melatonin has been studied for helping shift workers sleep during the day, with mixed results, though it may help some individuals. Caffeine is commonly used by shift workers to maintain alertness, and strategic timing can optimize benefits. Napping before or during night shifts can improve alertness, and even short naps can help. Accident risk increases during night shift work, and drowsy driving after night shifts is a significant concern. Long-term night shift work has been associated with health risks in epidemiological studies, including cardiovascular disease and some cancers. The International Agency for Research on Cancer classifies shift work involving circadian disruption as probably carcinogenic based on limited human evidence. Mechanisms linking shift work to health risks are not fully understood, and may involve circadian disruption, sleep deprivation, and behavioral factors. Drowsy driving causes thousands of crashes each year, and sleepiness can impair driving similarly to alcohol intoxication. After 17 to 19 hours without sleep, impairment can resemble a blood alcohol concentration of 0.05%. Signs of drowsy driving include difficulty keeping eyes open, drifting lanes, and missing exits. The safest response is to stop and sleep. Coffee and opening windows are ineffective countermeasures for drowsy driving, and only sleep reverses sleepiness.